Hello, and welcome to the Radiology Economics and Policy Learning Electronic Toolkit, REPLETE. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this session is entitled Coding Systems, ICD, International Classification of Diseases. This module is targeted to Level 1 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs. And so if you are in a program other than diagnostic radiology, please reference the REPLETE resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows. Describe the history and role of the ICD coding system. Outline the rules and processes by which ICD codes are applied when reporting radiology services to payers, and explain how professional societies influence the coverage process, thus ensuring appropriate patient access to radiology services and procedures. Here are some additional resources listed alphabetically by author for those who would like to learn more about the topics in this module. We've talked several times before about the payment chain, the things that need to happen behind the scenes before and after you render a service for you to get paid for your work. I introduced you particularly to correct coding as an important link in that chain. In the prior module, we talked about CPT coding. In future modules, we'll get in the weeds more about edits and modifiers. In this module, we'll focus on ICD coding. One of the messages that hopefully you've grasped by now is that without the right codes, you don't have a claim. The 1500 form, illustrated in paper here, but used in its electronic version by almost all of our practices, requires that everything we do gets distilled into codes. The most important of these codes are CPT codes, which describe what we did, and ICD codes, which describe why we did it. Payers will only cover for services that they deem medically necessary. And since many process literally millions of claims each day, these are rarely reviewed at the individual manual level. Instead, computer algorithms search CPT codes and ICD codes for each claim and look for matches and mismatches. When a CPT code is submitted and the rationale or diagnosis matches one on an approved list of ICD codes, that service is typically deemed, at least at that screen level, medically necessary and usually paid. So getting the right ICD codes and the right CPT codes on your claims is critical. And you'll remember the example I've used several times, a CT of the pelvis. If the only clinical history you provide is something related to appendicitis or signs or symptoms thereof, you'll typically get paid. But if your history got truncated because headache was the only word that came through from your ordering physician's office, or the only word that you dictated from that list in your report, then you probably won't get paid for that service. Now, these codes can all get confusing, so let's take a second to remind you about CPT, current procedural terminology maintained by the American Medical Association CPT editorial panel and updated annually. CPT, as we've talked about, describe what services you rendered. Now, the challenge here is usually getting a code. Remember, there aren't as many codes as many would like to describe all of the emerging technology in a rapidly changing specialty. For 2018, we're on target to have 10,155 CPT codes, which isn't that many when one considers that a large portion of the CPT book comprises laboratory and other tests. So, our professional societies spend a lot of time working through the complicated process we've previously described to make sure that there are enough codes to keep up with what we do as radiologists. ICD is the topic of this module and is very different from CPT. It stands for the International Classification of Diseases. It's not maintained by the American Medical Association. It's maintained by the World Health Organization. And it's not updated annually, but rather revised on an ad hoc basis. ICD describes why a service was rendered, signs, symptoms, or diagnoses. And here the challenge is often related to applying codes. Perhaps there's too many codes. So with the recent change from ICD-9 to ICD-10, we went from about 14,000 ICD codes to about 70,000 codes. So again, the problem here is really almost one of too many codes. This level of granularity presents lots of challenges with accurately and adequately capturing clinical history from your report. Without new levels of detail, your coders won't be able to assign codes and won't be able to get you paid for your services. So, under ICD-10, our documentation burden as physicians has increased. But additionally, at the payer policy level, matching that information with newly mapped lists of covered diagnoses that are established for particular services can create payment challenges as well. So, unlike for CPT, where professional societies typically work on getting more codes, for ICD, our professional societies spend most of their effort helping physicians use existing codes and getting payers to recognize those existing codes to get paid appropriately for those services. Let me give you some examples of the level of granularity in ICD-10 coding. These new codes can be anywhere up to 7 digits, as I'll talk about shortly, but I'm going to focus on some 6-digit examples for lower extremity atherosclerosis. Here are 3 codes with descriptors that at first glance seem pretty similar. Just a minor change in how a disease presents. The atherosclerosis is complicated by intermittent claudication rather than gangrene, for example, changes the code that you need to use. And for a given diagnosis, changing the side of the body, here simply from left to right, also changes the correct code to use. So hopefully you can see why capturing this clinical information from your referring physician, from your technologist, and from your electronic medical record, and getting it into your radiology report for your coders to use is so very, very important. Now, let's step back a bit and talk about the ICD process. The American Medical Association, as I talked about in my last module, just celebrated CPT's 50th birthday. ICD has been around a lot longer. ICD-6, that's just 4 versions back from what we're using now, was implemented by the World Health Organization in 1949. ICD-7 was implemented just 6 years later in 1955, and ICD-8 10 years after that in 1965. Things started slowing down. It took another 10 years until ICD-9 was implemented, and then another 26 years for ICD-10, at least at the world level. That was a huge transition, as we'll talk about some more. Going from ICD-9 to ICD-10, we went from about 14,000 to about 70,000 codes. That's about a 5-fold increase. The complexity of that change was a large part of the fact that even though the World Health Organization released ICD-10 in 1994, we didn't implement it here in the United States until some 11 years later, in 2015. And for those who think that we're done with all of these transitions, the World Health Organization is currently scheduled to release ICD-11 in 2018, just after many folks were breathing a sigh of relief that they had just survived a huge transition. In the last module, I shared with you a screenshot of the CPT editorial panel. They're all physicians and other qualified healthcare professionals in the United States, all appointed by the American Medical Association's Board of Trustees. And their focus is ensuring that services described in CPT are those that are in common practice in the United States. The composition of the ICD-11 Joint Task Force, as you see here, is quite different. First of all, being sponsored by the World Health Organization, it's an international body. Second, while there are some physician representatives, you'll see that the participants include medical librarians, computer scientists, epidemiologists, and statisticians. That's because ICD is designed not only to assist in claims processing, but also for a variety of public health and epidemiological purposes. The fact that practicing physicians play such a small role, however, contributes to some of the clinically irrelevant and rather humorous codes that I'll share with you later in this module. Again, there are 2 types of ICD codes that apply to medical billing. We mentioned briefly in the CPT module, PCS, Procedure Classification System. This specific type of ICD codes describes procedures and is used functionally by many hospitals as their surrogate of CPT codes. Since the focus of what we're going to be talking about in this module, though, is physician services, we're going to be focusing on the clinical modification. That's signs, symptoms, or diagnoses. So when you hear ICD, for all intents and purposes, think CM, not PCS. Now, when we talked about CPT, I told you about the accuracy imperative and the de minimis approach that coders are instructed to use when physician documentation is incomplete or confusing. There is a similar hierarchy of coding for ICD, and this is the rules here. The coders are instructed to code each clinical scenario to the highest level of available information. So you need to make it available to them for them to code it for you. And the hierarchy that they're instructed to use is signs, symptoms, and diagnoses. So if they have diagnostic information, then they're going to not have to report signs and symptoms. Sometimes, though, you won't have a diagnosis, and therefore the signs and symptoms will matter. The bottom line is that coders code best when they have the most accurate, complete, and definitive information to use. Let me give you a few examples about how this works in real life, focusing on a couple examples of chest radiography and abdominal and pelvic CT. So here's a not uncommon scenario. A patient with cough and fever is referred for a chest x-ray in your outpatient imaging center. You interpret the chest x-ray and report out lobar pneumonia. How is your coder going to code that? Well, here you've got clinical history of cough and fever, your diagnosis in your report and under your impression is a type of pneumonia. The coders are going to report that out with the appropriate ICD code for the type of pneumonia that you have described. Why? Because that's the most specific diagnostic information available. Let's move to a slight variant of that. Again, patient comes in with cough and fever for a chest x-ray, but in this case, her chest radiograph was normal. How are your coders going to code that? Well, there is no ICD-10 code for normal, so they're going to code to the highest level of diagnostic information that's available to them. Those are the signs and symptoms that led to the referring physician ordering that study, and hopefully the signs and symptoms that are documented in your report. Cough and fever are the diagnoses that will get you paid for this service. Let's pivot now to a not uncommon scenario for an abdominal and pelvic CT scan. Here's a patient who presents to the emergency department with nausea and vomiting, and when you review the CT scan, you identify and report out early appendicitis. So, not unlike my first example here. Yes, there are codable signs and symptoms, but they're not the highest level of diagnostic information in this case. Your specific diagnosis is, and so your coders will report this using the appropriate ICD-10 code for the type of early, uncomplicated appendicitis that you describe. But what happens if this patient doesn't have appendicitis? Hopefully you can see where I'm going. She came in with nausea and tenderness, and that's what your coders are going to code out because that's the highest level of diagnostic information that's available. But sometimes all we give our coders is rule out appendicitis, and we don't give them anything then to code our cases. So what about rule out? Well, the bottom line here is that anything that says rule out is going to be a worthless order. Documentation of rule out, while it may help you get into the head of what your referring physician is thinking about and what they're looking for, is not going to be a codable diagnosis. And don't just take my word for it. Take the rules of Medicare as the gold standard here. What's Medicare say? If the results of the diagnostic test are normal or non-diagnostic, and the referring physician records a diagnosis that is preceded by the words that indicate uncertainty, probably, suspected, questionable, rule out, or working, then the interpreting physician, that's you or me, should not code the referring diagnosis. Instead, Medicare tells us that we should report the signs or symptoms that prompted the study. It's our job, if we haven't captured that information, to get it, because we should be reporting it. We've talked about this radiology workflow map before. Remember, we as radiologists typically focus on the steps in blue and assume that our business offices will take care of the rest. But if all we give them is garbage in our reports, then that's all they'll have to work with. So, it is imperative that our practices also focus on the front end. Each of these encounters along the way is an opportunity to capture clinical information and get paid better for our services. But that's also information that can help us provide more meaningful interpretations and thus better help our patients. And so, there are a lot of reasons why we need to capture good ICD-10 information. In addition to providing better reports and minimizing rejections, it is becoming increasingly important for other reasons. We'll be talking about Medicare's quality payment program in a future module. It's part of the MACRA legislation. One thing, though, that physicians will soon be graded on is the costs of services that they render compared to the complexity of the patients they see. So capturing detailed ICD-10 information will be important to make sure that your patients are appropriately risk adjusted. Sure, it's good enough to have an ICD code that gets you paid for your service, but you're going to have accurate and complete ICD information if you want Medicare and other payers to risk adjust you so that you don't get dinged because you're doing too much on patients that you're reporting out as less sick than they truly are. And as we move into an increasingly data-driven world, capturing this information will be imperative to make good practice business decisions, particularly if your practice is considered risk-bearing contracts, as many of ours increasingly are. And it's going to be important as well for those of us who perform policy-focused health services research to be able to have good data, to leverage payer claims, to be able to produce the most meaningful information possible to help our practices and our patients alike. As ICD transitions from 9 to 10, it's gotten a lot of attention recently. As ICD-11 is beginning to show up on the horizon, there's some lessons to learn. Aside from the documentation and coverage burdens I've already described going from 14,000 to 70,000 codes, there's some real nuts and bolts logistical issues to think about. Many of our billing systems simply weren't prepared for this transition. Many software vendors, years ago, set up their ICD-9 fields to accept only 5 digits and only numbers. So they would have choked if we moved to 7 digits with both letters and numbers too quickly. Let's talk about the structure of codes to show you what I mean by this here. So an ICD code under 9 basically was up to as long as 5 digits. There were parts of it that focused on the category of disease, the anatomic site and severity, and some rules that show which are numeric, which are alphanumeric, and where all that stuff fits together. Less important for us as physicians, rather than this point here, that we went to a new coding system that now requires sometimes as long as 7 digits, with a variety of different fields for a variety of different, very specific points of information. And it's a mix of alphanumerics in very specific spots. So if your system was set up to only deal with 5 digits and purely numbers, it wasn't ready to deal with ICD-10. That's part of the reason that this implementation took so long. ICD-9 was a simple world. A sprained ankle, a common reason for a radiograph in the ER, pretty much was described all the time by the ICD-9 code you see listed here. When we move to ICD-10, we move up to 27 codes. The 3 variants that you see here, and then you take those 3 to the third with the additional 7th digit to identify the encounter, and you can see how this gets very complicated very quickly. What does this all mean for radiology? Well, we went through a big transition from what it meant from going from 9 to 10. It's something that my colleague Meg Fleming from Emory University spent some time looking about. Now, ICD-9, life was a lot easier. When we looked at a year's worth of claims from our practice within our Emory Health System, we submitted about 590,000 claims across that part of our practice alone. Interestingly, we only used less than a quarter of all ICD-9 codes to describe that many, meaning 75% of all ICD-9 codes were never used by our big academic practice. And importantly, of all claims, 90% were billed with just 348 codes, or 50% with just 37 codes. So folks got pretty scared moving into ICD-10 that, gee, we're going to have 70,000 codes. This is going to get out of control really fast. But that really didn't happen, at least in our practice. A paper that AJ Jallavant will soon have out in the JCR showed that the transition to ICD-10 was really a little bit more than a speed bump in our practice. Sure, we jumped up to 70,000 ICD-10 codes, but in a huge practice like ours, we only used 10% of all those codes, and 90% of our services were billable with fewer than 1% of all of our codes. So what's the point here? The point is that you don't need to worry about all 70,000 codes. You need to focus particularly on the ones that will impact the unique nature of your practice disproportionately. So ICD-10 coding is pretty easy if you're a breast imager, when just 8 codes describe over 90% of all your work. But if you're a general radiologist, things get more complicated. We have a community division of radiology, which performs a broad spectrum of radiology services. And from a coding perspective, that division is really a microcosm of our huge academic health system when it comes to ICD-10 coding. But If you're in a general radiology practice, though, you still only have about 500 codes that you and your coders really want to know and know very well. And so when you're trying to figure out, how do I educate my physicians? How do I educate my coders? How do I educate my referring physicians? How do I create a meaningful computerized physician order entry system? There's only a finite amount of codes that you need to worry about that will impact a hugely disproportionate amount of your services. But you're saying, I'm not a coder. This isn't my problem. Yes and no, but you are a physician, and hopefully you'll soon be a practice leader. And so you're not only going to need to document clinical history, findings, and impression in your report, but hopefully you're going to be in a position as captain of the ship to help promote system-based processes to help improve communication and documentation, which is going to be critical for shared success across the entire enterprise. Getting this information from your referring physicians, from your patients, to you and then to your coders isn't easy. Interoperability remains a challenge for many of our practices. We at Emory have a large informatics team, but you may not have those resources in the practice that you'll be joining, particularly if it's a small, community-based practice. But there's a lot of workarounds to capture that information. Here's a screenshot from a CT scan that a colleague shared with me recently. That health system didn't have a good mechanism for their CT techs to enter clinical information into the radiology information system and get that information efficiently to radiologists. So their techs simply typed it into screenshots that was available at the time they reviewed studies on PACS. Back in the days of ICD-9, you could say this history that you can read here was way too much. But this is actually the kind of granularity we're going to increasingly need under ICD-10. So when you ask your front office and your techs to get you clinical information, what do you ask them to do? They're not physicians after all, and you don't want them to be doing full history and physicals. But they are smart people who will be talking with your patients. And so focusing on the 3 W's, what, when, and where, and capturing that information, as Matt Hawkins, who's now in our department but in his prior work from University of Cincinnati has outlined in the AJR, is going to be critical for getting this information and helping improve not only the clinical information to help you provide the best interpretation possible, but also help ensure that you get paid appropriately for your services. I'd suggest taking that a step further with the 2 Ps and asking them to capture that information from the perspective of both the patient and that patient's presentation. Let me show you what I mean. Let's take that last emergency department head CT case. The patient got hit in the head multiple times with a meat tenderizer. And let's assume the scan was normal. So pain today in head is part of the information that's available. But what's really going to be much more meaningful for ICD coding here is going to be these details. It provides much richer information and hopefully is going to allow your coders to apply some of the very specific codes we've talked about and will continue to talk about. Now, what if the examination was positive? Well, remember the rules of ICD-10 coding. Signs, symptoms, diagnoses. Your coders are going to be looking to your report, what you describe, to be able to code that study accurately and appropriately. And so it's going to be this level of detail that you're going to need to put in your report to give your coders the information they need. They're still sometimes going to need that additional information as well. And so you want to make sure you capture as much as possible so they can figure this out on the back end. No sense for you as a radiologist to try to figure out what is or isn't sufficient. Let's leave that to our coding professionals. Now, some of these codes you may not like. They're complicated. They may be silly. I'm not saying I'm advocating these, but I'm telling you what kind of granularity you need to deal with. Please don't shoot the messenger. Stabbed while crocheting, walked into a lamppost, injured at swimming pool at a prison. These are all very specific ICD-10 codes that are out there right now. So again, that screenshot that may have seemed silly to you, it's actually information you probably need to be able to accurately code some services. Now, here's my favorite. Think about that one for a second. Really? I didn't make these up. I'm just telling you what you need to do to report ICD-10 codes. Finally, let's get back to the payment chain again and talk about the intersection of CPT codes and ICD codes. We only get paid when these 2 things overlap. So how does that process happen? Well, payers make up coverage policies, and they all make them up a bit differently. Medicare has 2 ways of making coverage policies. They can do it at the national level through NCDs or national coverage determinations. The policies are basically made in Baltimore at CMS headquarters through a formal and bureaucratic process. But most policies for coverage get made at the local level through LCDs, local coverage determinations. Sometimes the processes here are a lot less formal, and so your relationship with your local physician carrier medical director can be very, very important in influencing them to make good decisions. Sometimes it's going to be a lot easier to approach them with peer-reviewed literature, clinical expert information than it is to deal with the folks in Baltimore at the national level. How about private payers? Well, each of the many, many private payers across the country has their own rules. Some are pretty transparent and some are not. So they're going to need to be approached each individually in very different ways. These are all battles that we as individual radiologists can't fight on our own. We do much better if we all work together in a coordinated manner. And that's where the ACR and our other professional societies come in. The ACR has a team, a huge team, and the resources to interact with Congress through its lobbyists and help include things important to us in new laws. It has a team of folks from economics who have good relationships with folks at CMS at the national office, who can work with CMS during the rulemaking process to include information to make sure that we and our patients are considered as CMS puts forth new policies. We have a large carrier advisory committee that works in a coordinated manner to share information for radiologists, boots on the ground, to work with their local carrier medical directors to ensure good policy all across the country. And we have a large managed care network, again, enabling radiologists to build these relationships in a meaningful way and be able to provide good and useful information to those physician carrier medical directors as they create their own coverage policies. So in summary, ICD is the system by which providers communicate signs, symptoms, and diagnoses to payers. Medical necessity relies upon concordant CPT and ICD codes and is a prerequisite for appropriate payment. Capturing accurate and detailed information in real time will be critical for the financial well-being of your practice. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the REPLETE initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in REPLETE.